afternoon and good evening to you. Thank you for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based out of DRC. Dr. Ngashi is also the Principal Advisor to the Director General of Africa CDC. I will now hand over the floor to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon, colleagues, depending on which part of the world you find yourself at this time. We are very pleased to welcome you again to this week's press conference on behalf of His Excellency, the Director General of Africa CDC, Dr. Jean Kasea, who couldn't join us today because of other pressing engagements. But it is always a great pleasure to give you an update on the situation of outbreaks on the African continent. At this time, as many of you may be aware, we are dealing with multiple outbreaks at the same time on the continent. We have the Rift Valley fever that is going on right now in Senegal and Mauritania. We have Ebola in the Democratic Republic of Congo. We have cholera and Mpox that we have been reporting for quite some time now. And today we are going to take you through at least those four, just to give you an update on where we stand with the numbers, but also with the response. I think with that, Director, if we can get the slides on the screen. Next slide. Yes, I would like to first start with this wonderful news that Africa CDC and WHO have just signed a framework of collaboration, to bring the strengths of the two organizations together to strengthen the health systems across Africa, and also advance together our commitment to improving the health security and the sovereignty of the African people. The slide has disappeared. Addis, can you get the slide back? I think this, the framework has identified some priority areas of collaboration between Africa CDC and WHO, which is also building on the recent most wonderful experience of us working together in the management of outbreaks on the continent, as it is demonstrated by the incident management support team that was established that really brought the best of our two organizations. We are all united by a shared vision of our leaders on the continent, what we call the Agenda 2063. We all want to build a healthier, safer, and more self-reliant and prosperous Africa. Next. And some of the key areas that were identified in that framework is the area of health systems and very important health financing that we all know the global crisis that is going on, and really the urgent need for Africa to get its act together and find ways that we can sustain the programs on the continent. The area of health workforce and service delivery, which are critical. The areas of preparedness and response. We have already this collaboration that has started around pandemic preparedness and response. I think this is now the opportunity for us to strengthen that. The area of innovation and digital transformation, in particular, the digital transformation of the primary healthcare. And finally, is the area of equity and climate resilience. I think those are some of the key areas that are included in the framework of collaboration. Next. Another very important news is that this week, starting from Monday, there is the Global Primary Healthcare Conference that is going on in Addis here. As you can see, that was attended by the Director General, Dr. Jean Kaseya, the WHO Regional Director, Prof. Mohamed Janabi. We also have UNICEF represented there. We have the Minister of Health of Ethiopia, all of them again discussing how primary healthcare, which is the backbone of our systems on the continent, but also the anchor of our agenda on universal health coverage on one side, but also health security. Now the discussion is how do we strengthen primary healthcare to have those strong, resilient, and equitable systems that can help us really advance our agenda on health sovereignty. Next. Now, coming back to the overview on public health events, as you can see, 5 diseases that have really remained on top of the outbreaks on the continent this year, 2025, with Mpox still dominating in terms of the number of countries that are affected, 26, and cholera dominating in terms of the number of cases and the number of deaths that are reported this year, but they are joined by measles, dengue, and Lassa fever. But when look at the overall situation as the cumulative of the moderate and high risk events that have been reported, remember last year we reported 219 events. This year already where we are, as of October 9th, we have 175 high risk events that have been reported, slightly more than the 3/4 of the 2019. On the high risk, we have 50 compared with 72 last year, and on the moderate risk, 125 compared to 147. That to say that we are really on to exceed the number of public health events, moderate and high risk, that were reported last year. Now, I would like to start then with the first outbreak. It is the Rift Valley fever that is serving right now in Senegal. As of April week 40, we have registered 90 confirmed cases, 11 deaths, and the case fatality rate, which is around 12.2%. This outbreak, as you remember, was declared on 21st of September 2025. And for the week 40 that we are reporting, there were 62 confirmed cases compared with 28 the week before, and 5 new deaths compared to 6 the week before. When we look at the profile of those most affected, it's mainly men. Males make 55% of cases. And in terms of age group, is the 15 to 35 years that make 61% of all the cases. There are 3 regions that are affected in Senegal, 6 health districts within those 3 regions, with the vast majority of cases that are concentrated in Richard Toll, 52%, St. Louis that comes second with 36%, and then Dagana that account for 4.4%. In terms of the number of contacts that have been listed, there are 90 contacts. We see that not very good progress in terms of contact tracing. All these cases have been tested in the laboratory with both IgM and PCR testing. There are also ongoing outbreaks in animals, 21 cases that have been reported in animals, no deaths yet, but vaccination is already underway. But at the same time, Senegal, just as we reported before, is also going through other vector-borne diseases like malaria, chikungunya, dengue, and the West Nile virus. Now, some of the actions that have been taken at country level, I think surveillance is being strengthened, as well as risk communication and community engagement among the major actions that are being undertaken to control the outbreak in Senegal. Now, on Ebola, since it was declared on the 4th of September 2025, there have been 337 samples that have been tested, 53 confirmed cases so far, 31 deaths, and one health zone, I think, that is affected. That means that the good news is that this is now 10 days that there had been no new confirmed case in the DRC, and the outbreak has remained confined to one single health zone in one province. But when you look at the situation overall, some of the important highlights is that for the week 40, there were no new deaths that were reported. In terms of the active cases that are under care, there are 8 confirmed cases and 20 suspected cases. And there were also 14 recoveries, I think, that were discharged that week. Now, in terms of the profile of the people that are affected, 60% are females. And there have been 4 cases among the healthcare workers, and these 4 cases have all passed on. Now, and some of the other highlights, I think on the contact tracing, DRC is doing very well. 1,787 contacts that have been listed, 97% of them that have been followed up. On the contact ratio, it is 1 case and 32 contacts listed, doing very well. Really exceeding the expected minimum average of 20. And also that the number of cases among the listed contacts has remained low, 0.9% of them that have turned positive so far. In terms of bed capacity, their still capacity is 40% so far occupied. But the good news is that vaccines have been deployed, 25,000 vaccine doses that have been deployed, almost 19,000 people that have been vaccinated so far, including 291 frontline workers and 610 contacts. The situation right now, they still have some stock of a vaccine in the field, 6,870 doses that are still there. As I said before, this is now 10 days that there has been no new confirmed case, giving some hope in terms of for the control of the outbreak. Now, coming to the Mpox situation, I think overall, when we look at week 39, we still see an increase in the number of suspected cases and also in the number of confirmed cases. The number of confirmed cases are the ones that have seen a high increase, but it's also because of the testing. The case fatality in terms of this, there have been 15 cases among the suspected cases and 6 among the confirmed. But when we compare the number of cases this year, 2025, with 2024, we have already exceeded the numbers of last year. 148% of cases reported this year, coming to 119,000 on the suspected cases and 34,812 confirmed cases, making 177%, just confirming that this year we've had many more cases compared to what happened last year. And the same also on the death side, where we have 498% of deaths this year compared to the 45 cases that were reported last year. But overall, when you look at the overall trend, I think the trend is good in the sense that the weekly confirmed cases have declined by 65% when we compare with the peak week in 2025, which was week 19, where there were 1,620 cases. But in week 39, we had 560 cases. That is good news. The same also on the confirmed cases. We see also the decrease when we compare the average of the most recent 6-week period. We had about 514 cases compared with 1,442 during the EP weeks of 17 to 22. That's again good news, around 64% decline. And also added to that is the fact that we've also seen improvement in testing coverage overall that have increased from 30% to 56% during the last 6 weeks. But when we compare the performance of different countries, just picking the 17 active countries right now, we see this trend that there are about 8 countries that are still on the upward trend and 9 countries that are on the downward trend. But of those that are still increasing, I think there are 3 that are of great concern because the other 5 are increasing but on small numbers. But the most concerning ones are Kenya, where we see 67% increase, Liberia, 24% increase, and Ghana, 20% increase. I think those are the countries that we are much more concerned about, and I'm going to take you through a detailed situation in each of those countries. Next. Let's start with Kenya. What we see that if you notice from the epi curve is that from week 23, there has been a steady increase of cases in Kenya. But when you compare what happened in week 39 with the week before, you see that both the number of suspected cases, the number of confirmed cases are all going up. No, 23% on suspected cases, almost 2% on confirmed cases. The profile, I think, of the most affected are males, making 51%, with children less than 10% of cases. But some of the main highlights is on the testing side, Kenya is doing very well. I think they test everyone, and all the tests that get into the lab are all analyzed. That's the coverage of 100% and the testing rate of 100%. But there are still concerns about the test positivity, which is too high, 60% during week 39 compared to 73% during week 32. It still remains on the upward trend, meaning that surveillance is still predominantly passive surveillance. That's people that come to consult because they are sick, not people that are picked because of active surveillance looking for cases in the homes. That is of great concern. We can also see that correlated with the contact tracing, where Kenya still stands at 1 contact for 1 confirmed case. I think that's a problem because we expect an average around 20 cases. That it is the weakness of surveillance that we can see really reflected in those numbers. So it's important to say that the peak period in Kenya was observed during the weeks of 33 to 38, where there were an average of 36 cases. But also important to say that these cases are concentrated in the urban areas. In Mombasa, that account for 41%, Busia 15%, and Nairobi also 15%. Those 3 alone account for 71% of all the cases reported in the country. Also important to say that among the contacts, I think 2% tested positive, just indicating that I think they could have identified more cases if most of those contacts were identified and tested. But on the positive side, vaccination is going on. I think they received the first 10,000 doses of vaccines. I think all of them have been used. And now there's a new allocation of 20,000 doses that is also going very soon to be deployed to Kenya. In Liberia, we see a similar trend. Since EP week 21, the numbers have been going up. When you look at the situation during the week 39, we see the same, an increase of 226% on the suspected cases, going up from 47 the week before to 153. Same on the confirmed cases, 88% increase from 40 to 75. Also on the number of deaths from 0 the week before to 4 during week 39. On the profile of the patient, 63% are males, and children below 15 years make about 15% of all cases. Now, some of the main highlights on the testing, Liberia is doing very well with a testing coverage of 100% and testing rate of 100%, but concerns also, just like Kenya, with the test positivity rate, which is high. It was 66% in week 38. It is 49% during week 39. It's a slight decline, but we'll really wish that that decline is maintained over time, also to translate improvement in the surveillance. But if you look at the number of contacts that have been listed, it's about 2,413 out of the cases that have been identified recently. If you look at the ratio of that number, is 7 contacts for 1 case that is confirmed. That still tells you that there's really weaknesses in the surveillance that also correlate with the high test positivity rate. But we can also say that when you look at the confirmed cases, they did average 56 per week during the weeks 33 to 38, and that the cases are mainly concentrated in the Mpox County, about 70% of all confirmed cases in the country. It's also important to say that of the 156 active cases, 88% of them are being managed through home care. I think that is also one of the factors that need to be followed very closely if that's not contributing also to the increase in the numbers that we observe. Vaccines have been deployed. I think 20,000 vaccines that have been deployed. And in addition to that, currently, there is the interaction review that is going on, that is going to look at some of the successes, but most importantly, identify the weaknesses and come up with recommendations that are specific to Liberia that can help the country bend the curve. And then the situation in Ghana also, as we can see on the epi curve, since week 19, we have also seen in Ghana a steady increase on the number of cases. But when you look at the situation during epi week 39, the number of suspected cases has gone down, but the number of confirmed cases is still going up. There's a 18% increase, and the same week there was 1 case, 1 death that was reported. But in terms of the profile of those that are affected, 55% are males, and children make about 15% of all cases. Ghana is doing very well on the testing side. The testing coverage stands at 100%. The testing rate stands at 100%. But the concern also is the test positivity, which has now gone up from 33% the week before to 57% the week 39. And again, when you look at the contact, we see a low ratio of only 4 contacts for 1 confirmed case. Just to say that there's a common pattern in these 3 countries that are going up related to the weaknesses in the surveillance, with most of it still predominantly passive, and the fewer contacts that are being identified and being followed. Now, when we also look at the peak, the epi week 32 to 37, which was actually the peak period in Ghana, they had an average of 38 cases. But on the contact side, out of 3,449 contacts that have been identified, 16 had tested positive. And also most of the cases are concentrated in two places in the western region and also the greater Accra region, that both account for 70% of all cases. But it's also important here to mention that in Ghana, Mpox testing has been now decentralized and operating in about 15 regions, which is good news, bringing testing closer to the regions. And also the vaccination started on the 3rd of October with 33,000 vaccine doses that were deployed. Now, turning to cholera, the situation that shows that the number of cases has continued to increase. By week 39, we have now surpassed the total number of cases that were reported in 2024. That is 272,324 cases compared with 254 and 75 cases in 2024. We have the case fatality rate also higher than in 24, that's 2.3% compared to 1.9, and the 23 member states that are affected compared with 20 in 2024. Now, currently, there are 17 member states that are active and 6 member states that are inactive. But our concern is that with many of these countries now moving into the rainy season, I think there's a strong possibility to see resurgence, as we have started also observing that in some of the countries that had done so well and saw the decline in the number of cases. Now, looking at the performance of the most active countries here, we notice that we have 3 countries that are going up when we compare the number of cases during the last 6 weeks, from week 34 to week 39, and compared to the 6 weeks before, which is 28 to 33. Now, we see Chad, Angola, and Burundi all going up, with a percentage of change estimated around slightly over 160%, all of them. And at the same time, we also see the other 6 countries, which is the Republic of Congo, Ethiopia, Sudan, DRC, South Sudan, and Somalia, that are going down. Now, what we see is that sharp surge in those countries, I think starting with Chad, but also the same maintained in other countries. But of great concern is the fact that Angola had already saw a sharp decline in the number of cases, but we've seen recently a rise again, I think, over the last 2 weeks. That shows that that's a resurgence, which has got the risk even to worsen as we move into the rainy season. But we see also stable outbreaks, but still remaining on the upper end of the burden. That is in Sudan. It still remains the highest burdened country, although the number of cases have shown a sharp decline of 40%. Showing that this is really encouraging progress. But at the same time, we see that the transmission still continues. But we have also observed declining cases that are in South Sudan, in DRC, and also in Somalia. Now, trying to do a deep dive on Angola, when you look at the epi curve, you see that it's mainly the last 3 to 4 weeks when we see that rise again. And when you look at the week 39 compared to the week 38, there's a 29% increase. We look at the number of deaths as well. I think 10 deaths in week 39 compared to week 8 the week before. In terms of the profile of the people that affected, males make 67% of all cases and 62% of deaths. And children account for 25% of cases and 32% of all deaths. But some of the most important highlights is that the hotspots are now in Lunda Norte. and the emerging clusters that have been observed in Which and some of the sporadic flare-ups in Wheeler. At the same time, I think it's also important to say that Angola had done vaccination with the oral cholera vaccines. 2 million doses that had been were received in early July. Campaigns were started, and they have continued along also with the strengthening of the water and sanitation. But some of the key drivers of cholera outbreak in Angola is still related to unsafe water, gaps in sanitation, and also observation that some of these have been concentrated in mining communities and also the river-dependent communities. I think that's where the epidemic is most predominant. Now, it's important to say that the Angola have seen the rise. I think it saw its peak around week 17 and 18. And now, again, we see that coming back. That means that there's a resurgence, I think, that need to be monitored very closely. It's also important to say that there are new areas that are being affected from the previously controlled areas, but we still have concern that if this continues, even the areas that have controlled might also see again a resurgence with the waning of the immunity more than six months following the vaccination of the single dose that happened in that country. Next. In Burundi, we've also seen the same picture from about week 26. There's sharp rise that has been maintained until now, even accelerated during the last 3 weeks. When we compare the week 39 with week 38, we see the same trend, 26% increase. But the good news is that there have been 0 deaths, which is good news. But some of the hotspots are really centered around Rugombo, with spillover that is now toward the Bujumbura province. Now, some of the key drivers is the scarcity of water in Burundi and also unsafe water sources and the challenges related to the poor sanitation in those areas that are being affected. But also important to mention that Burundi, because of the proximity with the DRC, there's also the population movement with the influx of the people that are coming out of the DRC. Now, that's what we see, that rapid rise in the cases in September, which then increased the stress on the capacity for case management in the treatment centers. And also this is happening in the context of resource gaps, especially for the entire response in general, but in particular for the WASH component of the response. And in summary, just to say that we are seeing the Rift Valley fever outbreak that is going on in Senegal with a concurrent outbreak in Mauritania, but that has got also a further risk of cross-border spread, in the region. There are ongoing efforts that are being deployed to support the Ministry of Health to really control the outbreak. At the same time, we can say we see very encouraging progress in the DRC. The outbreak has been confined in one province and one health zone within that province. 10 days that there have been no case, no confirmed case reported. All the medical countermeasures, both the vaccines and the MAB 114, have been deployed, and surveillance is performing very well. As we can see, I think we hope that they will be able to maintain that trend to get this outbreak under control in the coming weeks. On the Mpox, we really see encouraging progress also in the previously high burdened countries. We see the decline that have been maintained, but it's more the recent upsurges that we are concerned about in Liberia, Kenya, and Ghana, where we really see the urgency of deploying the vaccination, but also intensifying the response on the ground. On the cholera, we have seen also encouraging progress in countries like Sudan and South Sudan. We've seen the drops, very encouraging, but the resurgence that we see in Angola and also Burundi are of great concern. even calling for more attention as we move into the rainy season. And I think just to say that as you have seen, Africa is dealing with multiple concurrent outbreaks that are putting a lot of pressure on resources. And as you can see, the vast majority of them are of zoonotic spillovers, and calling for really strengthening the multi-sectoral coordination, particularly the One Health approach that need really to be overemphasized again. But at the same time, the whole issue of access to medical countermeasures remains real. Reason why we really need to also step up our R&D and local manufacturing effort to make sure that Africa has the capacity to produce its own vaccines, therapeutics, and diagnostics. And we are also happy to see that this collaboration framework that was signed with Africa CDC and WHO is going to go a very long way in really improving this effort toward more collaboration, more integration across the continent as we deal with the challenge of multiple public health events. With that, I would like to stop there, Director, and thank everyone for your attention, and then we can open up for comments and questions from the participants.
Thank you very much, Dr. Ngashi. Let's take the first two questions. We have one from Ian Bior, is a Reuters journalist based in Senegal. The question is regarding RVF in Senegal. How often do RVF outbreaks happen in the region? That's the first question. And is there a link to climate change and RVF outbreaks? And then when was the last time Senegal had fatalities of any kind linked to RVF? I will hand over back to you for your response.
Look, I would like to ask Dr. Merao if you can take that question.
All right. Sorry. All right. Thank you very much. All right.
Go ahead.
Okay, thank you very much. Sorry.
Yeah, try.
All right, thank you very much. Apologies for the tech hiccup here. Yeah, regarding RVF, RVF is almost endemic in the northern region of the country, and it was reported ever since the 80s. And it has been really becoming more frequent these days across Africa. And it is, yes, it is related and closely related with the climate change and extreme weather events. You know, if you see torrential rain with quick floods, then sunny days, expect RVF in the coming days with favorable conditions for the vectors. So this has been the case, and some of those studies in that country, serological study, it is a virus is circulating at very low level in non-outbreak seasons, but outbreaks are coming every now and then, and it becomes very regular these days, not only in Senegal, but in the Eastern Africa region and across the board. So, yes, reporters have been there, and human fatalities were there. And like 2 years ago, like 10 years ago, in the 13s and 14s and 2013, 2014 zeros days, and this one, the current one, is really significant, and that you have seen the number of cases that we are really monitoring. And this is not only that, this the whole trajectory of vector-borne diseases that you see, particularly like mosquito-borne diseases, are really expanding across the board that you have noted in our reports before, including the dengue fever and so on. So it is clearly related to with climate change as well as the extreme weather events happening here and there. And unfortunately, that region is also really with cattle herds and with porous border. People are moving here and there, and all these are really indicative variables. Yeah, thank you very much. Back to you, Director. Thank you, Dr. Williams.
Thank you very much. Let's take the next two questions. We have Lucia Blanco, is a Spain International News Agency correspondent based in Africa. The question is, would you say the Ebola outbreak is closer to be contained? And have you been able, as Africa CDC, to raise more funds for this response? Over to you, Dr. Ngashi.
Thank you very much, Director. I think we can say that it is progressing in the right direction. I think we know the history of DRC. Some of the previous similar outbreaks in remote areas have been controlled within 3 to 4 months. And in this case, I think the first case was reported around the 20th of August and the outbreak declared on the 4th of September. As we can see now, it's just about 5 to 6 weeks actually since the country has been in the response. If within 5 to 6 weeks, we can already see the kind of trend that we see now, that you spend more than a week with no case, it shows that it is the trend, it is really progress in the right direction. And if they continue like this, they might actually repeat the success of that was seen in Equator, where it was controlled in 3 to 4 months. Now, the second question was about the resources. I think there is considerable challenges that we need to recognize. You know, when you are dealing with so many outbreaks at the same time, there is also a competition for resources. And this is happening at the time when there's the global financing crisis, as you can see. Reason why we have not been able to mobilize the same level that we did for Mpox at the time. I think that's the reason why we continue really to push very hard on the resource mobilization and calling on all the partners really to come to the rescue of these countries and provide the needed resources. I think we don't have enough. We're still in the active resource mobilization phase.
Let's cross over back to the floor. We have Abuja Rachel. She's from the news agency in Nigeria. Abuja, you have the floor.
Thank you very much, Director, and thank you, Dr. Ngashi, for your presentation. My first question will be, you mentioned that the majority of current outbreaks are due to zoonotic spillover. How is the African CDC working with member states to strengthen the One Health approach at community and national level to prevent such spillover? My second question will be on local vaccine manufacturing and access. Now, I would like to know, are there any incentive that African CDC will be giving to manufacturers? For example, in Nigeria, we have NAFDAC. NAFDAC oversees vaccines and commodities. In Kenya, we have the same thing too. Is there anything African CDC is doing to harness all of this so that researchers and manufacturers don't have to go to 53 different countries to get access or to get registered in order for them to give out suppliers? My last question will be, you made emphasis on the need for Africa to step up research and development, and of course, the local manufacturing of vaccines and diagnostics. What current step are we taking as African CDC to ensure that sustainable access to medical countermeasures across the continent? Thank you very much, and over.
Thank you, Abuja. Back to you, Dr. Ngashi.
Yes, thank you very much, Rachel, for that very interesting question. I think I'll take the one on local manufacturing, and then Dr. Mirawi, is our Director of Surveillance, can take the one on the One Health approach. I think on local manufacturing, that's just to say that this is one of the top priorities of Africa CDC. As you have heard, the DG always emphasize on it to say that if we get the African manufacturing right, it is the second independence of this continent. That's the reason why I think all efforts are being made really to provide incentives to the manufacturers. First, we do have this annual event that we gather the member state and the manufacturers together, to just discuss some of the challenges and also hear from both sides how we can address that. Because there's no way that we can address the challenges facing the manufacturers without listening to them. And secondly, there are three specific areas that Africa CDC is working on to help the manufacturers. One is the area of resources. We have really worked with different partners, with Gavi, to mobilize this AVMA that brings down the 1.2 billion that's in support of local manufacturing. We worked with Afreximbank. We have the 2 billion also from Afreximbank. That's resources that are coming to support the local manufacturing. And we continue with different other stakeholders, the African Development Bank, to mobilize resources. That's one area of work. The second area is also thinking ahead that even if manufacturers produce, the issue of registration, of regulation that you have just mentioned, Rachel, is an important one. We have been, first of all, working with the national regulatory authorities to strengthen the capacity, to empower them to be able to do that, because of the concern that at the end of it, we don't want the regulatory process to be repeated in each of the 55 member states in Africa. That explains the reason why Africa CDC has supported AMA, to ensure that once AMA becomes operational, that will ease everyone's work, because you have only one regulatory process that then can be used in all the countries. Before AMA, you might not be aware of that Africa CDC had to deploy one of the senior staff here to go and lead AMA during the transition until the director was elected. Now that there is a director that is elected, we continue our support to make sure that AMA gets all the capacity that they need and the resources. We'll be working with them to become fully operational, to be able to support you in the concern that we've just raised. And finally is the fact that even if you produce, even if it goes through the regulatory process, the issue of market still remains. We have experience on the continent where some of the manufacturers produce some of the medical countermeasures during the COVID time, but at the end of it, there was no market, that all those investments were just wasted. That's the reason why we have also worked with the head of state to establish the African Food Procurement Mechanism, which is under the leadership of Africa CDC, to be able to pull the demand of different countries and give you the market that you need to be able to thrive and then move forward. I think that is on that side, but for the R&D, as you know, we are working with key partners like CEPI and others there to make sure that we then strengthen the R&D capacity on the continent and be able to develop the clinical trial networks and everything that we need to make sure that Africa has the capacity to conduct its own research based on its own problems. I think Dr. Merawi can take the question on One Health.
All right, thank you, Dr. Ngashi. Thank you very much for raising that.
Dr. Merawi, you're on mute.
Okay.
We still cannot hear you.
Yes, can you hear me now?
Yes.
Yes, go ahead. Go ahead.
All right. Thank you very much. For raising that important question regarding zoonotic. I think we live in the world. We share with animals, and a significant number of pathogens are coming from the animals. Knowing this from day one, we of our establishment, we have set what we call it One Health department under the Surveillance and Disease Intelligence division. And the One Health department has like 4 main areas that we focus. One is zoonotic diseases, the other one is climate change and health, the other one is food safety, and the other one is antimicrobial resistance. We have very robust One Health strategy here in Africa CDC. And when it comes to surveillance, we are currently working in creating multi-sectoral coordination mechanism in each member state. This multi-sectoral coordination mechanism, different member states have different levels of engaging the Minister of Agriculture, Minister of Health, Minister of Environment and Wildlife, and so on together, under some under Prime Minister's office, some under another coordination unit, and so on. But we are really trying to create a multi-sectoral coordination mechanism in a number of member states. Why we need that? Because we want them to share information and data among themselves, and also to have a joint emergency preparedness response plan for any zoonotic disease events within the animal sector or wildlife and or with human. So that is one major activity that we are currently working on. The other area that we are currently working is zoonotic disease prioritization. What are those pathogens that we need really to worry more about, and in the animal world that we need to really focus and strengthen surveillance? We have done this region by region, and we come up with a very good list of priority diseases where we should focus surveillance and disease intelligence among those priority diseases. This exercise is done with multi-sectoral mechanism, and it is really what we hope that once it gets mature, data will be generated and shared, and we'll get a very good outlook on disease and disease patterns that really affect both animal and human. The other one is in climate and health, which is a big portfolio. You may have seen our recent strategic plans that we launched. That is also to really see the patterns of disease spread affected by or climate sensitive disease patterns across the board that we have noted from different extreme weather events across the continent. So we have the strategy. We are really pushing to create multi-sectoral coordination mechanism in member states. We have a continental coordination with the AU organs like the AU IBAR, African Union Commission, and we are also pushing prioritization of zoonotic diseases. Thank you very much. Back to you, Director.
Thank you, Dr. Merawe. Let's cross back to the floor. We have John Agaba. John is a science writer and writes on vaccines. John, you have the floor. John, if you can hear us.
Thank you so much for the presentation, Doctor. Mine is about the Corella in Africa. Despite lots of interventions like the OCV vaccination and all these, that we continue to see like an upward trend like the last 3 years. Maybe if you could talk us through like what could be the major reason behind this upward trend, and do we have like innovative ways that we are trying to do to stop this Corella on the continent? Thank you so much.
Thank you, John. Back to you, Dr. Ngashi.
Thank you very much, John, for that question, which really reflects what every African's concern at this time is. That concern is also shared by our head of state. As you remember, that the president of Zambia, who is the champion, the AU champion on cholera, convened a meeting. just to reflect on the same with 20 member states that were the most affected. The meeting was attended by at least 10 heads of state and vice president, just to reflect on what can we do to achieve two things. One is that we stop the current outbreaks, and two, we lead the continent toward elimination by 2030. Out of that, they issued a call to action. In the call to action, they identify some of the key challenges that are facing the continent. Some of them include the fundamentals. It is the weaknesses in access to clean water and sanitation that explain the reason why we have these recurrent outbreaks on the continent. And if you look at the things that you've just mentioned, they are all health-related sector interventions, OCVs and all that, and treatment, and and the weakness has been the fact that the multi-sectorality of the response has remained weak. That we haven't seen really the other sectors of water and sanitation rising really to be able to provide those interventions that are critical, not only for outbreaks, but also for human development, because water sanitation are part of the development of any country. Look at the wash infrastructure in other countries, very weak. Look at the peri-urban areas, where really there's almost no development. Go to the rural areas, you get the impression that most of these facilities are concentrated in the cities, not much in the rural areas. I think that's why our head of state issued that call to action. Following the call to action, we then, as the partners under the leadership of WHO, UNICEF, and Africa CDC and other partners, we developed the Continental Outbreak Response Plan. And very soon, we are also establishing the Continental Task Force that will develop the elimination plan, the cholera elimination plan on the continent. Some of the things that will be really the main priorities of that is the fact that we really need to identify all those areas that are at risk of cholera, and then also look at the fundamentals, strengthen, number one, the wash infrastructures in all those settings as number one. And two, we have also suffered because of limitation of investment in these sectors. If you see in the call to action, the head of state recognized that we need to also put some of the domestic resources that are invested into these interventions to prevent cholera. And the third area that was also identified, that really eliminating cholera or stopping all these outbreaks is not going to happen if you do not also look at engaging with communities, at the forefront of the response. I think that is one of the key things that we met, really civil society organizations, community leaders, religious leaders, all of them are going to be mobilized to be able to not only educate the community, but also support these very important services at community level. And finally, one of the things regarding to the cholera vaccine itself is also that as we move forward, this also requires, even on the vaccine, for us to increase our capacity to vaccinate, for which we are also pushing for the local manufacturing of oral cholera vaccines on the continent. I think those are some of the key pillars of the response moving forward that will help us control the current outbreaks, but also lead toward elimination. I think just a few elements of the response to your question, John. But perhaps I think Dr. Merai mentioned something that is also very much related to this, is the challenges around climate change. I think there's a very huge agenda that Africa is also embarking on, really to help the countries also think through the impact of climate change, especially on health, which include also cholera, and also have some of the mitigation measures. I think that will help them, not only the wash infrastructure, but also climate resilient infrastructure that will help with the control of the cholera outbreak. Over to you, Director.
Thank you. We just have two more questions here. We have one from Mohammed Ismail from Sudan. The question is, Sudan is currently experiencing a severe dengue fever outbreak. What are the Africa CDC's plans for Sudan at this time? Let's take the next question. We have another one here The question is, what are the mechanisms in place to ensure real-time data sharing between member states, especially in resource-limited settings? And how is Africa CDC addressing inconsistencies in surveillance data quality? Are there plans to expand Africa CDC's partnerships on this front? Back to you, Dr. Ngashi.
Okay. Yeah, thank you very much, Director. I think I will start and then I'll invite Dr. Merawi and also Matthew to come in. Matthew on the dengue response and Dr. Merawi on the surveillance and data. No, just to say that if I start on the dengue outbreak, dengue is a vector-borne, vector transmitted disease. And that means that the control of dengue also passes through the control of mosquitoes, which are also linked even to the discussion we've just had now, that the climate change is also one of the factors that is contributing. Now, what Africa CDC is doing in all those countries that are affected by dengue is, first of all, to make sure that we have a very good mapping of the main hotspots of the outbreak in South Sudan. That is one. And then the second is that we have a risk communication and community engagement that educates the communities on the behavior of the vector and also means of preventing the mosquito bite. I think that's transmit to that. And then number three, we are also working on some of the preventive measures that include the vector control, which include both the destruction of the vector with insecticide, but also some of the environmental measures, that will drain the waters, the breeding site of the mosquito, destroy the larva, all those environmental measures that help us control the vector. That's the kind, the support that we are providing to South Sudan to do that. And then on the real data, I think Matthew will come in there. On the issue of the data, Africa CDC has got a very ambitious agenda for the data transformation on the continent, which include, first of all, strengthening the data systems of the member state, and also including that as part of the primary healthcare digital transformation that we are also doing to make sure that we start right from the communities where we need every African person to have an individual digital health card that contains their health information in, every community health worker to have a digital gadget that allows the community health worker to collect information at community level. If you are now talking about surveillance in particular, the 1 million community health workers we have on the continent, following the survey that we just completed now, will be now also used as our community-based surveillance officers, that are empowered with the digital gadget to be able to collect information at community level and forward that information into the system. In addition to that, we are also trying to see how we can digitalize the primary healthcare facilities, also to make sure that the data can be forwarded in real time. We have a partnership right now with the University of Oslo, to work on the DHIS tool, because that is the tool that most of these countries are using, to then add an emergency module to the DHIS tool, which is the DHIS tool tracker, that will help us also collect information on surveillance, on emergency response, and be able to send that. But above all that, I think we have been working for a couple of years now with the member state to sign the data sharing agreement, that allow the member state to share their information with Africa CDC. And we have a huge infrastructure that is sitting here in Addis, the Continental Data Center that is also being now finalized, really equipped and so on. It will be operational very soon. That will be now the repository of all the data that come from the member state. I think just to brief you a little to some of the, the ambitious project that Africa CDC has on this topic. But I have my two colleagues here that can also come in, just fill in with any additional information. Let me start with Matthew on dengue fever outbreak in South Sudan. Yeah.
Yeah, no, thank you. Thank you very much, Dr. Ngash. I think you elaborated very well on the dengue response. Now, just to address the question of what Africa CDC is doing to support Sudan in responding to dengue. So one of the major constraints that we have been facing, especially in Sudan, is the issue of access. So the access to Sudan has been one of the challenge, but now there is some light where access is possible with the return of some of the government to Khartoum. So as we speak, there is a high-level initiative within the African Union through the Health and Humanitarian Commission, as well as Africa CDC, to send a high-level delegation to Sudan. And these delegations are going to Sudan hopefully by the end of this month to stand in solidarity with the people of Sudan and also understand some of the public health issues. It's not only dengue. Yes, we know the dengue fever is really causing a lot of morbidities, but we are also looking at other public health aspects, including strengthening the health system, because we know the crisis has really devastated the health system. So that high-level delegation is in the process. We'll go to Sudan by the end of this month, and it will work very closely with the authorities in Sudan to identify the immediate needs, and Africa CDC will be working very closely with the Ministry of Health to address some of these gaps. Thank you.
Yeah, Dr. Merawi, I think South Sudan is facing multiple outbreaks as well. In addition to dengue, they have cholera, we mentioned. They have Mpox as well. I think all those are outbreaks that have been reported this year alone. Dr. Merawi?
Yes, thank you, Dr. Ngash. I think you have touched it very well. And I'm really very happy that this question arises. I think surveillance data, data quality, digital infrastructure, all these are really very important variables that we don't usually talk in the media, and we don't really draw attention of the public. But the reality in the ground is there is not much digital infrastructure across the board. That is why Africa CDC, since the Director General was here, he was advocating for digital transformation of primary health care. And that is really the bottom line. So major challenges like digital infrastructure and digitalization of the health institutes and data sharing agreement, data standards and guidelines. We don't have really good quality data standards and guidelines that can really help different machines to read each other or share information and data across the board. We don't have workforce trained to do really integrate data from different sources and do advanced analytics for surveillance like disease forecast and prediction and so on. So we have really ambition like to operationalize the Continental Public Health Data Center here, which is a huge infrastructure that can really serve member states with as a federated data center for them and for us as well, and also a pipeline within it that can serve as a data lake that can mine data from different sources, not only health, from climate and other environmental data, and clean and archive and analyze with some level of machine learning and AI to do better automated reports and forecasting and predictive analytics. This is ambition. The roadmap is developed now. Currently, we hope it needs a really good investment in that space, but we'll make sure that it will be done within the next 2-3 years to have a full capacity that is really at continental level. At country level, I think Dr. Ngashi also mentioned that clearly. Thank you really very much.
Thank you very much. We have one last question from Kemo Cham of Mano Reporters. Kemo, you have the floor. Kemo, can you hear us?
Sorry, I think it was an error. I didn't intend to raise my hand. Sorry.
Okay, great. All right. So with that, we have come to the end of the briefing this week. I would like to hand over the floor back to Dr. Ngashi for your closing remarks. I've been reminded about the immunization forum happening in Dakar, Senegal. If you could speak about that as well. Back to you, Dr. Ngashi.
Thank you very much, Director. I think, first of all, I would like to sincerely thank all the participants. I think they are our motivation really to maintain this accountability of Africa CDC to the African people. And we also enjoy this moment with them because they are also our voices, and champions also out there to also communicate the work that we are working together to go to achieve our vision of that safer, healthier, and prosperous Africa we all aim toward Agenda 2063. But there are two very important events that I would like to announce. One is the immunization summit that is taking place in Dakar, Senegal, for West African countries. It is a ministerial forum where I think the region is going just to look at the progress that we have made in immunization, look at the challenges, and see how do we accelerate our immunization agenda toward Agenda 2030 that we have decided ourselves. And also make sure that we eliminate the zero doses that are contributing so much on some of the outbreaks that we have been just reporting to you. We also see the outbreaks of cholera, polio, all these that are happening when we have an intervention that can help us eliminate that. That is that forum that is taking place in West Africa. Another that is from 17th to the 19th of October in Dakar, Senegal. And then from the 22nd to the 25th, we have the Continental Conference of Public Health in Africa, CPHIA, which is taking place in Durban, South Africa. And this year, the main theme is moving towards self-reliance to accelerate progress toward universal health coverage and health security. I think we've heard the discussions about Africa trying to be self-reliant, whether on local manufacturing or on financing. I think all those are things that we are going to discuss there. The really resilient and performing primary healthcare systems. We are going to discuss that in South Africa as Africa and come up with a common voice on learn from each other, hear the science around those key topics, and also come out of that with some clear understanding of some of the doables that can help this continent really accelerate its progress in a way that strengthens its sovereignty. I think those are the two events that we are really extending the invitation to all those that can participate. You are most welcome to participate. It's because of you that really these events are being established. You have a lot to share. You have a lot to communicate about. Now, with that, Director, I would like just to conclude by saying that what we've heard today is the challenges of dealing with so many outbreaks and so many public health challenges at the same time. The determination is there, as you can see, both from Africa CDC, from WHO, from all the partners that are working together, most importantly from the member state itself. I think we see that high-level commitment that really we work together to put in place the necessary interventions and the responses to improve the lives of the African people. For that, we have heard in this discussion that we cannot overemphasize the importance of multi-sectoral coordination of which One Health on one side, and with One Health also the issue of dealing with some of the real challenges related to climate change and so on that continue also fueling even these outbreaks that we have discussed. We need more resources. I think there was even a question asking that if we have enough for Ebola. It's not only for Ebola, for all these outbreaks, we need more resources. And your voices are also important, for us to advocate together for all those that can contribute on the continent itself to also put down the necessary resources but most importantly, with our member state as well. As we can say, as we are moving towards self-reliance, we like also our own member state to walk the talk and also put down some of their own domestic resources. I think all those are things that we can work together with this community here that attend this press conference to also share that information and spread the news so that all those that are the decision makers can receive the same message from all of us as one community. With that, I would like to sincerely thank all of you for your attention, and we look forward to welcoming you again next week, same day, same time. Thank you very much, and bye-bye.